Afternoon or good evening, depending on where you are. I am Maria Palombini, and I am the director and leader of the Healthcare and Life Sciences practice at the IEEE Standards Association. And today I'd like to welcome you to this exciting premiere series, Global Connected Healthcare Cybersecurity Virtual Workshop Series. In typical IEEE SA fashion, we put a lot of words to a lot of great ideas. So welcome. This is the first in a series of 5. You see, we'll have 5 throughout the year, but today is our premiere one, and really excited to have you here. So with that, just real quickly, this is a exciting collaboration between the IEEE SA and the Northeast Big Data Innovation Hub. And with me today, co-hosting is Florence Hudson, who's the executive director of the hub. Hi, Florence.
Hey, Maria. Thank you so much for having me, and welcome everybody. We're so delighted you could join us.
Great. We're so excited to have you and this really great planning advisory committee. There's been a lot of great effort that went into this, and we're very excited to bring this along. So with that, just real quick, for those of you who are not familiar with IEEE, just wanted to share this very quick introduction. Our mission is advancing technology for humanity. We are the world's largest nonprofit technology association. We've been around for more than 100 years. We are global. We're in over 115 countries. So definitely all our work naturally is always with a global aspect in mind. So this is obviously you'll have access to download our slides because we want to get to the good stuff. These are just quickly the numbers I referenced for all of you. And then finally, you know, our work in the Standards Association, we produce more than 750 global standards. Our work is promoting innovation, looking how we use new technologies in a responsible and validated way, especially in the healthcare life science domain. And naturally, this is one of the main reasons why we're collaborating on the Cybersecurity Workshop Series, because we know that cyber breach, security vulnerabilities, patient privacy are all pertinent to us adopting and bringing new technologies forward in this domain. So this is our portfolio of activities. For those of you, we do industry connections, which are quote unquote our incubators, naturally standardization. We have our membership arm, which is the larger IEEE as well as the IEEE SA. We do conformity assessment, registries, and so on. So we have a great and open source, which is a very exciting new area, especially in HLS. So with that, I mentioned that I am the Healthcare and Life Sciences practice, but we have multiple practices in the SA. We have one in mobility, energy, telecommunications and connectivity, and foundational technologies. And their practices in that we have a specialized focus to bring the global community of volunteers together to incubate and collaborate and bring ideas forward for standardization and addressing these global problems that, that we continue to find in all these different technology applications. So with that, I also like to have Florence come and tell you a little bit about the Northeast Big Data Innovation Hub.
Excellent. Thank you very much, Maria. And welcome again, everybody who's still joining in. So I'm the executive director for the Northeast Big Data Innovation Hub, which is headquartered at Columbia University in New York City in the US. I know we have some people joining us from around the world, so thank you for joining us. The Northeast Big Data Innovation Hub is one of 4 big data hubs around the country in the US that are funded by the National Science Foundation. We're a community convener, collaboration hub, and a catalyst for data science innovation to address real-world challenges, which cybersecurity for connected healthcare is a real-world challenge. So that's one of the reasons we're focused on this. We have 4 focus areas, and actually this workshop and this partnership with IEEE actually applies to a couple of them. We have a health focus area. We have a responsible data science focus area, including security, privacy, and ethics, which are all elements of this workshop series. We have an education data literacy focus area, as well as urban to rural communities. So we're really delighted that we can have more of you participating. You could be anywhere on the planet or in the galaxy someday. I'm an aerospace engineer, I'm into the galaxy, you know, that can join us and collaborate with us on these efforts. So you could always look at any bigdatahub.org to learn more about that. If you could go to the next slide, please. So we really want to give a special thanks to our Connected Healthcare Cybersecurity Virtual Workshop Series Advisory Board. I know many of you are online today and many of you are facilitators. So you can see there are pictures here, and thank you for being part of this. We also really want to thank our workshop student assistant facilitators who work at the Big Data Hub. They're all Columbia University students and they're all incredible. And I really want to thank them for pitching in. They will be working. Somebody is making a fair amount of noise. If you're not speaking, if you could go on mute, please. Thank you. So, so the workshop student assistant facilitators will be in each of the 4 breakout sessions, helping the facilitators from the professional side to gather the notes and make sure we know like what type of input you have on your breakout. And then that will be used for the breakout facilitating leaders to present back to the whole team at the end of the day, actually at 1 o'clock Eastern. So we really want to thank them for joining us, Haruki, Macy, Tia, and Haley. On the next slide, what we want to do is just give you a feel for why we're doing this and what it's about. So I've been very fortunate that I've been collaborating with IEEE for a while, the Standards Association, on clinical Internet of Things data and device interoperability, and creating a framework called TIPS, TIPPSS, which stands for Trust, Identity, Privacy, Protection, Safety, and Security. And so this workshop is actually co-sponsored or presented by the IEEE Standards Association, which, as Maria mentioned, the IEEE and Underwriters Laboratories P2933 Standards Working Group on Clinical IoT, Data and Device Interoperability with these TIPS elements, and the Big Data Hub. So we wanted to do this so that we could bring more people together to address the challenges in connected healthcare cybersecurity. As you can see in the workshop series, we have 5 of them planned this year. They build on each other. This is the first one today on global connected healthcare, cybersecurity risks and roadmap. The next one will be in April on privacy, ethics, and trust in connected healthcare. Then in June, data and device identity validation interoperability. Then in September, connected healthcare integrated systems. And then in November, a connected healthcare technology and policy considerations discussion. And this is going to be a virtual workshop series this year because of where we stand with COVID-19. And then we'll see what happens into the future. Next chart, please. Next slide. So this is a high-level view of the agenda. We were very fortunate to have Julian join us. I'll be introducing him in a second, a couple of seconds, from Massachusetts General Hospital and Mass General Brigham. And he's been very involved in medical device cybersecurity and interoperability for many years. I used to actually look at his lab online years ago and see what he was up to. So after his keynote and Q&A at noon, we'll be announcing the breakout rooms and facilitators. That's also on the website. And each of the breakout sessions will actually go through 4 different steps, which you'll hear about. Maria will tell you after the keynote. Then after the concurrent breakouts, we'll come back at 1, hear the report back, then talk about next steps and introduce the workshop 2 and conclude by 2 o'clock Eastern is the plan. So that's our plan for the day, and we're really excited you're with us. And now I would like to introduce Julian. So Dr. Julian Goldman is an anesthesiologist at Mass General Hospital and medical director of biomedical engineering for Mass General Brigham. He's the director of the Medical Device Interoperability Program, which is a multi-institutional program founded in 2004 to advance medical device interoperability to improve patient safety and health IT innovation, which is so in line with what we're focused on today. So Julian, as always, it's such a pleasure to have you join us, and we look forward to hearing what you're thinking and what sort of things you think we should be thinking about. I think you're muted.
Perfect. Oh, no, now you can hear me, right?
Now we can hear you.
Before. No, my intent was for you not to hear anything.
Thank you.
Thank you, Florence. Appreciate the introduction. And I'm just really honored to help to kick off the series and today, and then just to perhaps stimulate thinking. And the first test is going to be to see if I could share my screen. Okay, could I have a virtual drum roll, please?
Perfect.
Now you're seeing
the presenter.
You're seeing the full screen?
No, we're
the
seeing
presenter.
the presenter mode. Yeah. There you go. Perfect.
Okay, are there any questions? Let's see what happens now. Is it still presenter mode?
It is. Maybe if you click on use slideshow at the top, will that do it? I don't know.
Sure, I will try. I will try. Okay.
Yeah, that's okay.
We will we will make it work.
Okay.
No, that's all right. We will.
There you go.
It's going to be almost perfect. It'll be.
This is what they do on Mars too when they have to figure things out. Perfect.
Just make it work. Well, thank you very much. Just want to do a time check. Okay, audio check is okay. You can hear me.
We can hear you. We can see you.
That's great.
Perfect. Thanks.
So to get the conversation going. You know, it's tempting to jump into talking about cybersecurity. I mean, why not? It's a pretty good topic. But the thing is with cybersecurity depends upon what you're talking about, the topic, the technology, and so forth. So the first question I wanted to ask is, what is global healthcare? So I think we'll talk a lot about what that is, as well as what cybersecurity is. And we'll start off with kind of the background on cybersecurity, kind of in a nutshell. The main thing is that it has to be considered in context. We have to talk about what is the system we're talking about? What are the boundaries in the system? What are the technologies that are used in that system? What is the architecture or architectures of systems that are connected? And you know, any cybersecurity expert or novice or wannabe will tell you that these things are really vital in order to make any sense and to think about cybersecurity. So global connected healthcare is certainly something that's seeing an appropriate energized state right now. And it really consists of a myriad of technologies and concepts that are all moving quickly. COVID-19 has certainly provided an impetus for developing rapid solutions. And so I'd like to move through some of these, flesh out some of these ideas throughout my presentation. So we'll have fewer words and more pictures or screenshots. So this is what we're seeing. This is from October. What a great, unfortunate title. It is not a good week for healthcare as health system IT execs react to recent ransomware attacks. So this refers to Nebraska medicine. And this is a big deal. You know, we have King of Prussia, we have Nebraska, large hospital systems that are affected. Now, part of the reason for showing this is to help to differentiate between some of the threats and attacks on hospitals, which are typically on health information systems or electronic medical record systems, in contrast to what we might think of as health IoT technologies. And of course, that's why we have to think about the architecture and the system and its boundaries. Otherwise, we jumble all of this stuff together. And, you know, schools are also affected. And here's an example of what happened in Massachusetts. But again, I'm emphasizing this is around ransomware attacks and what we're seeing with IT systems in contrast to the devices themselves. The whole, a lot of those attacks and a lot of that activity were connected to this ransomware activity alert AA20-302A. Now, for those of us who are not familiar with these numbers and this website, it's really worth going over to the DHS CISA website, and or just when you Google or Bing or whatever one does today, and searches for some of these things, you'll see that they'll take you right to the right place. And it's really worth reading these alerts. They're very readable, and the links are very useful, and you can educate yourself about what these things are. So this was really a critical activity that generated a lot of response, this alert. And I won't go into the details of it because there's not enough time. But as you can see, New Jersey Hospital, again, this is around ransomware, data breaches and ransomware, which is usually the focus of the newspaper accounts. However, I think this is a very interesting and important paper that was published recently. And as you can see, the paper makes a point that, and I'll read directly from here, Hospitals are already facing the consequences of omitting measures when their growing pool of medical devices essentially have not been considered in the cybersecurity kind of assessment. The more connections and the more devices, the greater the threat surface potentially. Well, more than potentially, since it hasn't been considered. And so I think this, paper, maybe it just underscores what we've already assumed and, addresses it in a more formal way, but certainly this is what we've expected and what we have been dealing with in many hospitals. So this is an advisory that was just released February the 16th, this month. So ICS Medical Advisory, and there's the number, 2104701, they all have that number. And this screen capture catches the kind of the essence of the vulnerabilities. And the point here is that this is a ventilator. This is Hamilton is a company that makes excellent high quality ventilators. This is a transport ventilator, which can be used for critical care. It's fairly widely used around the world. And there are vulnerabilities that were identified. Now, how were these identified? Well, there's a German organization that is systematically testing and evaluating medical devices. And it is that group called BSI that identified the vulnerabilities, and then using a process called coordinated disclosure, or kind of a formal process. They didn't just post the threats on the internet and say, hey, look at us, we found problems with a medical device. No, they did the socially responsible thing of disclosing it to the company and so forth and so on. And the end result is that there is, by the time this was announced, there already was an update or patch. In the latest software version for the ventilator addresses it. Also, it can be exploited, but one has to physically probably be at the ventilator. And frankly, it does not look like a high clinical risk vulnerability. Because what this does is it would allow someone to change the default settings of the ventilator. Now, typically, when a ventilator is set up on a patient, one at least would check the default settings and check all the settings. And these are intended for use by experts, respiratory therapists, intensivists, and folks like that. But this is not just some old issue. These are happening. They're being revealed, and I think what's good is we're seeing more energy and money being put into identifying existing hazards and then disclosing them and addressing them through proper channels. But I can assure you, as soon as this was released, there was a flurry of activity, and it takes time, energy, and money to address these things. And then, going back to what we just looked at, this prior slide, more interconnected environment, the more hazards that actually exist, the more that we're likely to see issues. And in terms of, these ventilators are not exclusively used in hospitals. They can be used in homes. And then when we think about our global pandemic and the need to care for patients in other environments, certainly we no longer can trust that everything will be installed behind a high quality, secure hospital network or equivalent. So in anticipation of some of these issues and in the recognition that it really takes a village of technologists and clinicians and societies and the FDA, regulatory agencies to think about and address the clinical risks related to cybersecurity, the American Society of Anesthesiologists formed the Cybersecurity Task Force over the last year. And this article in the ASA Monitor is freely available online, which talks about the formation. And the reason I mention it is not to tout the ASA. I think it's to show that this is a model that can be used by organizations to start to bring together experts to answer specific questions. And the next slide, this is excerpted from that article, and this emphasizes, here are some of the effects of cybersecurity attacks on medical devices: shutting down a device, distorting the display, affecting the remote control capability, person in the middle attacks, and modifying data. And if you look at the right paragraph, it points out if here's a what if. So what if a cybersecurity attack could remotely silence a device's alarm? Is that a clinically significant risk? Well, it's not clear what the answer is. We've seen the answers on both sides. There was a case like this last year, and the manufacturer said, Well, these devices are always used in a highly supervised environment, and therefore we don't think it's a clinical risk. Well, clinical practice is very diverse, and practitioners are diverse, and the patients are different. So this just shows that you know, when performing a hazard analysis and looking at risks, you have to think a lot about the specifics, the context of use, the type of device. And so the intent of forming that group was to help provide a means to answer questions like this. And I believe we need more groups like this with different domains and different experts, because it's not one size fits all, and you know, we're all learning together. And so I would encourage you to build on that and build out the community. So now let's look at these more practical issues that we've been facing with COVID-19. Now here's a picture. I don't know this patient. Actually, it's just a picture from the internet, not from Mass General. We have, this is typical, a lot of devices around a patient, infusion pumps and ventilators and you name it. And the problem is that once you have a patient with an infectious disease like COVID-19, you close the door, and you don't want those viruses to escape. It's nice to share, but not this. So what you have is a situation, it's a setup for being unable to hear patient alarms, clinical alarms, device alarms, technical alarms outside the patient room. Real issue. So this has been driving all sorts of ad hoc solutions that some of them are not good and some of them are so-so. I think it really reflects a challenge with the state of industry, the state of innovation, and the state of our ability to rapidly respond to something like COVID-19 patient care. So, when the patient is in their room, someone has to adjust the ventilator frequently. They have to adjust inspired oxygen concentration and other settings. And donning and doffing PPE could take anywhere from roughly, all sorts of numbers, 10 to 25 minutes. And doffing, of course, is particularly hazardous if it isn't done well. So that's an issue with ventilation, as an example. And other things that require frequent changes are infusion pumps. And so one of the solutions is to move the pumps outside the room, in which case you have long tubing and delays with starting or stopping infusions. But it gets the job done. It's a kludge. And this is really happening, as you can see. Again, just a picture off the internet notice all of the infusion pump trees outside of the patient rooms with long tubing to get the job done. This is how we're doing things today. So, here's kind of a little summary of some of the challenges caused by deployment of new ventilators with non-interoperable data connections. So the gap is we can't hear the alarms from the patient rooms. And the interim solution has been to have alarm sitters, alarm watchers, non-clinicians, for example, students sitting outside a patient's room, especially during a surge, and with the door closed, listening to alarms. And when they hear an alarm, they call a nurse over and say, "Hey, there's an alarm in that patient's room." This is the state of modern medicine, because we can't. It's one thing if you have a certain model ventilator in your hospital, model A, and if you triple the number of model A ventilators, well, you have a way to connect them. But if you buy model B or model C that have never been connected in your hospital before, because we don't have standardized interfaces that have all been vetted and tested, there's some time required to make those connections. And then not only are the alarms an issue, but also transmitting data to the flow sheets, to the electronic medical record. Also, there are ventilators that are pressed into service that were never intended potentially to be connected to things like that, or only under unusual circumstances, transport ventilators and others. And so if you want to quickly connect a medical device into some kind of data system, good luck. You may need the specifications from the manufacturer. In our experience, some manufacturers are very happy to solve this very quickly. Sometimes they work with a third-party integrator. Some manufacturers simply refuse to share the information on their interface. They consider that proprietary information. I won't comment on that, because I know this is being recorded. So ideally, you would stay outside of the patient's room, and you take out your handy dandy remote control, and you would control the infusion pumps, and you would control ventilators and other things. And you might be doing it from immediately outside the patient's room, looking through the window and actually looking at the screen. So there'd be really a very low risk of a problem. Now, but when you're dealing with technology like this, it can be a bit difficult to set up the remote control. Now, remote control seems like a crazy idea. Maybe some people think it's dangerous. But interestingly enough, if we use the Wayback Machine from Dr. Bullwinkle, you can see that around 2014, we worked with a large team, about 20 collaborators, in response to the Ebola virus disease, and the FDA was part of this team. And we asked, well, maybe we should have remote control of medical devices to reduce the risk of caregivers entering the patient's room during Ebola virus disease. And we prototyped this. This is our old lab. The new lab is prettier, but it got the job done. And there's lots of information about this published and on wherever. And it was, I'd say, one of the first collaborative efforts to really look at what are the clinical benefits, what are the hazards that could emerge from this, how can you make it safe, and is it feasible? And manufacturers, I think, took this to heart. And to some extent, it helped to lay the foundation for future work. And here's some of the future work. So just before the pandemic, Nihon Kohden released the NKV 550 ventilator with remote control. And so you're looking at the ventilator in the ICU, and you see the ventilator remote control here connected to that ventilator, and all the things you can control on the ventilator inside the room, you can control outside the room, which has many benefits. Not only could you avoid entering the room, but there are other benefits. Sometimes in order to assess it, well, always, in order to assess a patient on a ventilator, one doesn't just look at the ventilator. There are certain things that you have to do. Hold the breath, an inspiratory pause, an expiratory hold, make adjustments, and then look at the patient's response. And so this now facilitates that from outside the patient's room. And this is another photo that shows the installation. And this was the first deployment. The company had developed this prior to the pandemic, but we deployed this as the first clinical site at MGH, and then provided feedback to the company, and they made some rapid changes based on our response. And now this is widely available, and we're pretty happy to see it. And it opens up all sorts of questions about when do you actually need to go into the patient's room and manage the patient. Now, the other thing that happened as a result of the pandemic is that the FDA released several immediate in effect guidance documents. And what these say, this particular set, especially the one around ventilation and infusion pumps and monitoring, state in the lower left is the text. The FDA currently believes a modification would not create undue risk, and that specifically includes adding remote control. So this applies to currently marketed devices that are FDA cleared, not to experimental devices. So you're taking a currently marketed device and adding remote control. Now this starts to get very interesting. Now manufacturers could add remote control to their equipment without going back to the FDA, at least during the public health emergency, which now gives them the opportunity to obtain real-world evidence and clinical experience with the usability of those systems. So fantastic enabler of innovation that the FDA conceived of. And this is kind of how you find it on the website. We won't spend time on that. But one of the companies that did take advantage of that opportunity is Medtronic, with their PB980 ventilator, very widely used critical care ventilator. So they developed a firmware upgrade and software tool called OmniTool, which they've initially provided to us for evaluation, and is now readily available to any people who own and use the Medtronic PB980 ventilator. And the OmniTool allows remote control of that ventilator. And so we were provided with that, and we worked with Medtronic, and we set that up in our lab. Now this is the newer lab. So Florence, as you can see, it's prettier than the old lab. And we set this up in our lab in Cambridge. And here's the setup. We found a willing volunteer mannequin with a mechanical lung. This is the Medtronic PB980 ventilator. And this is a patient monitor, and so forth and so on. This is the basic setup. And then by remoting into the computer, using a secure connection, this is a screen capture from my house. And when you write Medtronic, make sure you add an E, because I didn't. Medtronic PB980 ventilator controlled over a secure connection from 8 miles away. So this system, you can see the image in the lower left. You see the patient, and you see the system, the ventilator, and then you see all the controls. Now this opens the interesting question of how far away can you be when controlling a medical device, and which medical device? And is it okay when you're just outside the room? Is it okay when you're 8 miles away? What if you're just outside the room, but you can't enter the room because of the patient's illness, and maybe there's a half-hour or 20-minute delay before you can have the required level of PPE before you physically interact with a ventilator or other device. So there are a host of research questions around what is safe remote control, what is the risk benefit, what is the situation, and also what is the role of imaging or real-time video so that you can actually see the change. Also, in this example, you can see the waveforms from the ventilator, which are typically considered essential when you make changes to a ventilator settings, because you see the immediate response of the patient to the ventilator settings. So there are layers of considerations here, and some of these considerations have been documented and are available for general reading. We worked with Amy on a series of they're sort of consider them emergency use standards. They're consensus reports, and these were to help facilitate the emergency use ventilators that people were initially developing for COVID, and a host of other things. And the most recent consensus report was emergency use guidance for remote control of medical devices. So a number of these questions and considerations have been captured, and this is freely available. And this is now serving the basis for a more complete standard on remote control of medical devices. And we're trying to capture some of the considerations that I outlined for you. Now, what does this have to do with security? Well, if that's not obvious, then I'm not sure what is. But let's go into a little detail. So if you're controlling the device from directly outside the patient's room using the setup that I showed here, with Nihon Kohden with a dedicated cable, right? That long, fat, white cable. It's not connected to the network. There's nothing wireless. These are well-known devices. I think it's fair to assume that the security concerns are potentially much lower. Maybe they're a little higher than when you are controlling the device from right outside the patient's room. And then in this case, we connected over VPN and other secure technologies. And in these cases, you also have to consider user authentication or access controls. It's one thing in the ICU when people have to get access or maybe have an ID to be operating a ventilator, but the more you move the control further away from the bedside, perhaps you have to now be concerned about who is controlling and operating the equipment. But there's clearly benefits to these technologies for a whole host of reasons. And that is a good segue to this, to an initiative called the National Emergency Telecritical Care Network, or NETCN. Just kind of rolls off the tongue, NETCN. So NETCN is an initiative that was started by the Department of Defense from the Army's Telemedicine and Advanced Technology Research Center in collaboration with ASPR and the Society of Critical Care Medicine, and maybe some others, if I can interpret these logos. NETCN, I'll provide a bit of a timeline, explain a lot more about what this is and the implications of this initiative. I think it's worth taking note of this. So NETCN is part of a large concept of a virtual hospital with additional capabilities like remotely controlled devices like ventilators and infusion pumps, like closed loop control and autonomous capabilities. But initially, and on the left with phase 1 through phase 1, it's very much about building a virtual critical care ecosystem based on very lightweight technologies, based on smartphones, for example, and the ability to provide teleconsultation, critical care experts who might be anywhere in the country, providing coverage and support for bedside caregivers, especially in remote areas or rural areas where they do not have intensivists. Now, is that a common problem? Well, here's a map, and As you can see in the kind of orange, those are hospitals without ICU beds. And there are many hospitals that have 1 or 2 ICU beds. There are hospitals that have no ICU beds, and they certainly don't have adequate intensive care expertise. They may not know how to set up devices. They certainly need, basic assistance. And even if they have experts, those experts have certainly been overloaded. So the idea is to support not only, say, COVID-19 care, but that's the obvious use case, given that we're in the middle of a pandemic, but this would apply for mass casualty events in general. So the Netson initiative has been building out this system by using existing technologies initially to rapidly spin up the capabilities. So this is just some descriptions and articles around telecritical care for COVID-19, and early evidence of some of the work that's been done is all started late in the springtime. This is all brand new. So some of the vision are these things that are somewhat obvious, perhaps. What could be done with telecritical care for COVID, reducing exposure and access to resources, augment capacity, all of those things, as you might expect. And there's been a lot of thinking, a lot of energy, and there has been research funding to stand up the teams. And so as you can see here, there was in July, and it's all started late in the springtime. There were over 70 applications, I believe, for the initial teams, and these had to be teams that applied to help stand up Netson. 9 of them were selected initially in task 1. Those were down selected to 6 teams and then to 4 teams. And now phase 2 of the initiative is starting sometime in the next few weeks with 4 remaining teams. And those teams are all deploying. They've been taking care of patients. There's some data that I'll share. I'll skip this. So the notion again is light, very lightweight initially with secure mobile communication capabilities, synchronous and asynchronous capability, a means to register patients and assign them to caregivers. And then as this evolves, there will be medical device integration. There is some already, which is able to transmit that data. This is one example. This is we at MGH are on one of the 4 teams, and that team is led by the Geneva Foundation. It's called the Distress Team. Don't ask me what it stands for, but Distress is an acronym. And this is one company that's part of our team called OmniCure, and these are some screenshots from the app that lets you contact the provider, remote provider. Patients can sign up on their own. Bedside providers can sign up, and then everyone can communicate, and there's peer-to-peer communication. So, and there are a number of different support models, as you can see here, whether it's an e-consult, whether it's release coverage, because the staff are overwhelmed and so forth. So this is really, I think it's a real-world powerful example of something that was stood up very quickly. Here are some statistics that are fairly recent from these initial pilots. You see the 4 Netson teams. There are 238 remote experts that were registered, 240 local caregivers. So quite a few numbers. As far as the clinical impact, pretty low numbers here in terms of an actual save where a patient may have died. But in terms of helping the staff and reducing distributing workload, quite a few events. And so again, this is in its infancy, just started in the summertime. Future capabilities will include continuous monitoring of vital signs, tracking potentially of patients and devices, autonomous systems in the workflow, AI and machine learning, connecting all of the teams and all the patients into de-identified databases to help with learning and training. So, of course, interoperability of devices. There's already security for the communications. There will need to be more cybersecurity for all the reasons we talked about. So I think this is a good example of a real-world, active project that really touches on some of the themes that are relevant to this initiative. And I think it's important to recognize it isn't for COVID-19 only. It's also, sure, it'll be useful for COVID-21 and COVID-22, or, well, I don't know. Hopefully not. Hopefully not. But certainly, we all know that we need technologies like this to help us better manage patients, especially in austere environments. So some nod to members of our team at MGH, including some clinical staff and others that have been part of the work, focused on this area, whether it's NETSIN, the remote ventilation projects, and of course our kind of core MDPNP work. I put in a backup slide just to kind of make sure that no one sleeps too well tonight. So, you may have noticed in the newspapers, in the news, about the ice buildup in hospital oxygen vaporizer systems. And there's been quite a buildup of ice, especially in the wintertime. And this has caused a problem, especially in California and in some other areas out west, where it reduces the flow of oxygen delivery and it affects a number of things. And it's been in the Northeast, it's been all over. I just want to point out that, systems like this are also monitored sometimes through telemetry. And one also has to think about security and cybersecurity when we're monitoring our health, kind of our healthcare infrastructure and that ecosystem as well. And in terms of, okay, I just wanted to leave you with that again, just so you wouldn't think that, that there's an end. There isn't. This is the beginning. So with that, I'd like to thank you, Florence. Thank you to everyone for your attention, and I'm happy to answer any questions.
Thank you, Julian. It's always inspiring and you always make me think, which I really appreciate because it's my favorite thing to do. So, we'd be happy to take questions. If you'd like to put them into the chat, please do so. And why don't I get us started? So Julian, you've talked about so many cybersecurity risks. I created the smart building strategy at IBM, so I care about SCADA systems and, de-icing, vaporizers or whatever it is. And there's so much Internet of Things technology opportunity, there's sensing, but all of this stuff is hackable, right? So I think it's hackable at the hardware level, the software level, perhaps the firmware level, perhaps at the service level. And then you have the authentication issue with the humans and the devices. So as you think about all of this, are there any things that you've thought of where you could say, if we would just this could really help a lot? Do you have any of those in mind? And you might have 120 of them, knowing you, but are there any that you'd like to share with us? Because we're going into breakout sessions at noon Eastern today, and we're going to break up into security and interoperability, privacy, ethics, and trust, the software and hardware supply chain, like the SolarWinds issue, and technology and policy considerations. So anything you'd like to have us thinking about as we go into those, beside all the great content you've already shared?
Well, instead of pointing out something that I think is highest risk, I think I'll point out that we have a problem. We have an ecosystem, a medical device, medical technology ecosystem that is not lending itself to rapid solutions. And, of course, I went into detail there, but I think let's think about that. If you can't monitor patients once you close the door on them with COVID, and they can't communicate with their family, and we can't hear alarms, and if people are afraid to allow remote control of devices where appropriate, it's not the answer to everything. We have to make sure that we're thinking about the risk and context, and we have to understand the big picture. There's the patients, there's the pain and suffering of the patients and their families, the workload on clinical staff, the need to facilitate care of patients at home, especially with efforts to avoid hospitalization. And so I think really the hard part is finding the right way to balance the risk and capture how the trade-off can be done more efficiently without going back to square one every time. I remember a meeting at the FDA quite a few years ago when we were starting to work on remote device control, and this was under an NIH grant. We were proposing we worked with the FDA on a fake or mock regulatory submission. So instead of waiting for a company to submit this, let's just do it ourselves as a group and make it publicly available. And let's say we want remote control of infusion pumps. And we talked about a number of different technologies. And at one point, someone at the table said, well, this would all be fine, but I mean, if you want to have a smart pump, as long as it isn't remotely controlled, because that's really where we would draw the line. And we said, wait a second, what if you're standing right outside the patient's room? Patients in the ICU, a burn patient, on reverse isolation and very high risk of an infection. And what if you can stand directly outside the room and turn a knob on the wall that turns the knob on the infusion pump? So it's safer for the patient. And that, in that meeting, so that same person said, well, that would be fine. I mean, that's okay. So of course that's okay, right? That's safer for the patient and better for everyone. So I think if you could think about what the frameworks would look like, how do we capture these issues and concerns in a way that doesn't require us to start from the beginning every single time? I don't know the answer, but I know that is potentially a pathway for the solution that we need, because speed matters.
That's great advice, and in the P2933 working group, we actually have a use cases team, and they're trying to create the context around, so what does this mean? What about if it's Farmer Jones who passes out in the field, or what if it's a child that has a caregiver who's not in the room, or what if? So we're trying to get started with that, and we're going to invite people who want to join that working group to join. There are 2 questions in the chat, if I may ask them. Is there any work being done on integrating at-home diagnostics equipment into the healthcare system, I guess, from the perspectives you've discussed?
Oh, absolutely. Yeah, there's a lot of work. I think we still have some of the historical kind of architectural and data ownership and management issues. Does the data go into the EMR, and is it managed by, say, the hospital team or the hospital system, or is this managed by a third-party service, or is this managed by the patient? And there isn't one right answer, but the connectability of these devices has increased dramatically. Even all sorts of sensors that are important for COVID, as an example, like environmental sensors and the like. I think it's another use case, a family of use cases that would benefit from an examination like we just discussed, because one has to understand the risks and the benefits. Another example of trying to tease the risk-benefit analysis is something that's just happened over the last week with pulse oximetry and consumer or home use of pulse oximetry, and understanding how to interpret and apply that correctly if it's for non-medical personnel. And the FDA just a few days ago published an information page on that, because hypoxemia is so important in COVID-19. And of course, we're seeing more connected pulse oximeters too. So I don't know if that answered it, except to say I think it's the same answer, is that we need that framework to help understand the kind of hazardous situations, the risks to the patient's privacy and security and all that.
Yeah, it's very good advice.
What's the other question?
I'll tell you, we actually have a hospital at home use case, so I'm with you. So the other question has 2 parts. Where to start for the solutions? You've explained the problem from the device side. My question is part of the answer to address a hospital's infrastructure. Also, these problems of remote access and control of devices are analogous to other industries. For example, in oil and gas, we can now remotely run drilling rigs in the Gulf of Mexico. So where to start for the solutions? And one question, a part of that was to address a hospital's infrastructure.
Yep. Well, one direction that things are changing and moving towards, fortunately, are moving away from this point-to-point connections, point-to-point integration, and so-called interoperability, more towards platform-based approaches. And industry has used platform-based approaches for years. It has not happened in healthcare very much. So in these examples, think about the complexity and the alarm examples that we talked about. Those are point-to-point, sort of not really platform-based. There's some platform. They're mostly, how do we get this device to talk to that device, or this system to that system? But the more we move towards platforms with interoperable connections, the more we can just add sensors or actuators and connect that to other things. That's not a new idea. but it has been very slow to come to medical devices and healthcare. Part of our research in our program has been the development of the ICE architecture for the integrated clinical environment as a, initially, in prototyping open source versions of that for research. There are commercial implementations, and it's taking off now, thanks in part to federal funding, to good use cases, to real business needs and commercialization. So I think part of the answer is we have to embrace platform-based interoperability for sensors and actuators and apps. And that's the only way we're going to move forward in these, in our level of sophistication. You can protect a platform, using cybersecurity techniques and technologies that you have that possibility, but good luck trying to connect every, spaghetti wiring diagram when you set something up another way. It's just impossible. So I think that's critical. I mean, think about every corporate network and every, and of course, these other systems in industrial control. It's all gone to platform based. So that's the answer. It has to be platform based. Maybe more than one platform. We have smartphones that are more than one platform. You can pick a platform that will evolve different kinds for what they have to do. Maybe high acuity platforms, low acuity platforms, platform based.
Very good advice. Part of the standards work we're doing in this space is thinking about what a TIPS framework would look like. This interoperability framework that enables trust and identity and worries about privacy and protection and safety and security. It's a big ask, but we figure we have to start chipping away at it. And we have a sample of this is what it could look like, but there's a lot of work to do, right? A lot of work to be done. This has been wonderful. I think, there's two more quick questions. I don't know if we have time. Okay. Let's see.
Are they easy? They have to be easy.
Okay, let me see how easy they are. Okay. Latency is crucial for remote monitoring and control. In this context, IEEE time-sensitive networking and IETF DetNet are relevant. Interested in knowing any thoughts you have on this issue. And then the last one is, how do you see the control and ownership of the data?
Okay. Well, the first one about latency, there were studies on latency about 20 years ago with remote surgery, transatlantic, control of robotic surgery, and North America, I think Canada to somewhere in the U.S. And so there was initial work that was done. I think also it was started or funded by TATRIC, Telemedicine Advanced Technology Research Center in the Army. And those are, really interesting foundational studies. And there's been certainly a lot of work since then about what latency is needed. So, they found there were certain, say, constraints or requirements around human operator control. And I don't remember all the details, but, the jitter was a bigger issue than the latency. As long as latency didn't exceed something insane, then, people could accommodate. When it comes to things like remote control of medical devices, it really depends. We've been looking at that, in terms of what is acceptable, what's required, and what are you trying to do. So you could say, if a human is normally the one operating the controls at the bedside, do you really need any greater response than kind of the typical response that a human would need? But if you're trying to do more and coordinate something very specific with timing, like time an event, synchronize an X-ray to a certain phase of breathing, do something else, then you might need much tighter timing requirements. Say you're trying to deliver energy or defibrillate a patient. In fact, if you look at how I should say cardioversion is performed with what looks like a defibrillator, but it's kind of called cardioversion when you synchronize it with the ECG. That timing relationship is so important that those devices are usually connected with an analog, with a cable. That's still done because the timing relationship is so critical in the, I don't know, in the milliseconds, maybe, let's say it's probably sub 10 milliseconds, not positive, but thereabouts. So, systems like that still use analog, believe it or not, when you need to really get the job done and be certain. So even today, we have to think about timing relationships, even without kind of new technologies, but the way we've done things for a long time. Data ownership, well, you know, not for me to, well, I'll render an opinion. Obviously, patients at least have to own their data, obviously.
I agree.
But we do need, you know, but we need a thoughtful way to, you know, a new and better thoughtful way for de-identified or never identified data to be used to develop next generation of AI and other, you know, big data sets that could be used for anything. I shouldn't say AI. It's just for the big data sets that we need. For the many things that they're needed for.
Agreed.
A lot of smart people working on that. I'm sure. Yep.
Yep, we know a lot of them. Thank goodness. Well, Julian, as always, thank you so much for all your great insights. We really appreciate it. And I know.
Thank you for having me.
Absolutely, anytime. And I know I'm going to hand this back to you, Maria.
Yes. Well, thank you, Julian. That was really exciting, and we appreciate you taking on those questions from our audience, and I'm sure they appreciate it too. So just real quick, thank you, Julian. I was going to say, let me just share my slides so we can get into the next portion of the, let's see, here we are. Let me just get to the next portion. So we're about to go out in breakout sessions. You may have received the chat from our events manager, Christina. She's been helping us getting everybody to where they want to go. So before we jump in, we have shared with the facilitators that at their discretion, they can work with you on a few minutes for bio break, because we want to make sure we kept the agenda very tight knit so we can get through all these critical components. As I mentioned earlier, we have the teams are going to address, let me go back to the agenda for a second. 4 items in each breakout session, and we assume 10 minutes each, challenges and risks, gaps, potential mitigation strategies, and finally recommendations. So your facilitators will put in the chat a link to a template document to help collect all the ideas and workings of your particular workout group. Please note, and I'm sure the facilitators will remind you, that that session is going to be recorded, so you all will have opportunity to actually not only type things in, but talk as well. So we're recording it because this event's going to be available on demand for people who could not be here live this morning, this afternoon. And finally, once you're all together, Christina will give you guys an hour. You'll have a hard close, and that'll bring you back into main session, which is where we are now. And each group will be asked to present about a 10-minute roundup, basically of the main key points that came out of that discussion, so that everybody can share in the benefits of the conversations, even though they were not able to be in every room. So that's pretty much, in short, the layout for the next hour. If you have not been assigned a room in one of these 4 areas, just please drop a note in the chat, and Christina, or our team will get you to where you want to go if there's availability in that session. But if not, I leave it to Christina now to take over and put everybody where they need to go. Enjoyed the breakout. It gave you some time to get into what I like to call very hands-on, very interactive. And now we're going to ask each of the groups. I don't know if you empowered your facilitator to be the one to report back, or you guys nominated someone in your group to share, but we're going to ask each of the groups to give about a 10-minute roundup of basically the 4 core points that we asked you guys to address, and basically share with everyone how it went and what you talked about, the recommendations, mitigation strategies, risks, wherever you focused on from the point of view. Just to share with everybody, you know, as Florence mentioned, we had our student facilitators in each of the rooms, and they took great notes, and our goal is to share, hopefully within the next week or 2, the actual summary of all the sessions. We're going to share it with all of you, and also other registrants who may be coming on board to view this on demand. So definitely you will all have access to both verbal and some written form of what went on in each of these breakouts. So with that, I would like to have the nominated individual to talk about what happened in security and interoperability and connected healthcare session. We're going to call it session 1 for now.
Parthiv and Mode, are you
Parthiv?
ready? Yeah.
Mm-hmm.
Do you need time to regroup or are you ready? I think you're on mute mode. You're on, yeah, I said that in the right order.
Mm-hmm.
Sorry. Yeah, so we had a very lively discussion. We're just very energetic, so we didn't pay much time. We could not finish all the way. But it's pretty good discussion, and I nominate Parthiv to start. Go ahead, Parthiv.
I think you're on mute, Parthiv. You might be double muted. There you go.
Can you hear me?
Yes, we can.
So, I would like to thank all the participants and Dr. Goldman and Florence for being there and adding to the discussion we had. In terms of we did touch base upon the security threats and vulnerabilities that we have today. We talked about the future, and what keeps you up at night. And it was a pretty varied discussion. One thing I was sure, and again, I'm just, my thoughts, I'm speaking out here, and you'll get more details when we put our things in writing, is I think we have a long way to go. I think from my perspective, we haven't thought about these areas, given enough thought. And it's still work in progress from at least that perspective. And I do think that we would need to put in a lot more effort to get where we need to be, from what controls are being used, what we need to do for the current environment, and also start building to the future environment, because we talked about devices, trusted devices, and how that should be brought into effect. And also going forward is from devices, identities. It's not just human beings, it's not just processes. Devices will play an important role in the future. And then how do we bring that into the forefront? We talked about FDA and UDI, Dr. Goldman did. And again, I think we need to start bringing in all these factors in and really creating a framework that addresses also what should a device be when it's all dressed up, and what exactly information be provided, and that standard should be there. Because today it's difficult, we realize, to even know what exists on our network devices wise, and we are doing reverse engineering, as I mentioned in the conversation with Dr. Goldman, is we are building things back up. Instead the device is telling you who the device is, what do they do, what exactly standards they're following. We don't have any of that today. So that's where we are. And I think we have a long way to go. And the last thing I want to say is, from a device management, the device perspective, and incidents happens all the time, breaches happen, but we don't look at devices separately. We think the same incident response plan and program applies to it, which needs to be reconsidered in some ways. And do we come down to a break the glass procedure for devices, because we are dealing with human beings, with lives at stake, and health at stake. So I think these areas we need to reconsider and evaluate, but that's where we're at right now. So hopefully that helps.
Hey, thank you so much, Parthiv and Mode, for sharing that interesting point of view. I'm sure you guys had some great conversation, and I look forward to see, and we all look forward to seeing the notes. So next up, group 2, privacy, ethics, and trust in connected healthcare. Emily or Nada, will you be sharing some of the activities and discussions in your group?
Emily, would you like to start, and I will follow if you missed it? Is she there?
I think she's muted.
Emily, are you able to unmute?
Oh, I'm so terribly sorry. Yes.
No worries.
Yes, I'll start, say a few remarks, and then I'll turn it over to my colleague Nada. we had a wonderful discussion. It started off with a discussion about the distinction between the ethics surrounding issues in technology in general versus a more specific focus on applied technology issues for healthcare. And we are trying to figure out how to basically create a framework which allows for an openness to consider the discussions that are very ripe and burgeoning within the ethics of technology discourse, but ones that also then are specifically developed for healthcare solutions. And while we did have a discussion regarding specific frameworks that are currently being employed for more general applications of AI, for instance, we were brainstorming as to how we could develop very specific measures and standards for healthcare, as was already commented in by workshop 1. So one of the ways we would like to propose doing this to start to build this is by focusing on issues of perception that currently exist regarding where the problems in ethics and trust currently lie versus where they actually are from the practitioners' perspectives and more knowledgeable people within the field. And we discussed the possibility of having surveys about these things, surveys which might include consideration of the cultural differences in this space, as there are major differences in Europe versus the United States versus Asia, just for instance. And how we basically then can gauge those opinions, but not just culturally, but also individually. And one of the points that kept on recurring in our conversations was the role of the individual and the patient, and that when talking about ethics, we're especially all of us here who are on this call are going to be coming at this from the perspective of an expert in the field, but where is the patient in all of this? And how do we create frameworks that is putting the patient first? So again, we think that has to, the first thing we really need to do there is get some quantifiable information as to where the current state of actual concerns with the technology is versus perceptions over issues related to trust, and to do that with an international framework in mind. We also discussed the problem in having ethical frameworks at the point of a product's development, that might be a very different type of ethical framework than once it is actually deployed and is in the wild, as we say in data science. Should there, some of the policy concerns that might be there related to compliance of hardware, of pre-existing hardwares and compatibilities with software, we have to basically work to create a framework that has an openness and flexibility to it to anticipate things that might happen, but also things that there's no way of us actually possibly knowing. And so the problem with any sort of ethical framework is that it implies a reflection on something that already exists in the world. And so knowing that that's our vulnerability, once something is deployed and out there in the world, how do we create an openness for the fact that issues such as cybersecurity is a moving target? This is not static. Should we be looking to financial management and corporations as a way to think about risk management strategies? Should there be a Securities and Exchange type of commission like there is in finance, but for the healthcare world? Should there be regulatory bodies that then are operating differently from the manufacturers, the hospitals, the patients, and so on and so forth? How do we do that? Where do we place the responsibility? These are open-ended questions. We did not have specific answers for them, but we wanted to have a discussion as to where the responsibility lies about these things. And in terms of the mitigation strategies, we really just identified that there's major differences in the point of design of a new product, hardware versus software, and then again, the deployment of these things over time. And that the idea of having one framework for all of that might not be the final solution, and that we remain open to looking at models from other industries of applied technologies to consider, as this is a very complex ecosystem and sort of large chain where one particular framework might not be serving everything, given the nature of needing flexibility in this growing space. So Nada, would you like to add on to that?
I think you covered everything. I just want to highlight a couple of points. It's included in your summary as well, but somebody talked about big data analytics and data anonymization there, and how do we make sure that data linkability cannot identify patients, and the aspect of consent if you have big data collected over years, 10 years, and you are using the data currently. At the time when you collected it, you didn't take the consent of the patient that you will be using it for analysis. How do we deal with that? And also there was the issue of data sharing and also the open source data, and how do we protect data in that case? And if you say we will use anonymization, what about aspect? Because I saw this is one of the messages or one of the kind of note in the chat area. They say, what about genomics data? If you keep it in the open source, it can identify relatives and so on. So yeah, these are my extra points. I think you covered it already.
Nada, your comments just remind me of one last one last conclusion we had, which was actually recognition of the need for allowing the space for innovation to also happen. And the more restrictions that we have in these frameworks, that potentially could limit innovation. So we just want to be aware of that as a factor. How do we build a framework which is conservative in the sense of protecting privacy and vulnerabilities, but also to leave things open enough that we can continue to build these things and have new solutions to problems? And I love the example from the keynote of that even something as horrific as COVID, that we can look at some of the silver linings, that there were some opportunities to explore innovation when regulation backs off a little bit. So how do we sort of find that sweet spot of compromise between the two?
Final thing, I think it's already, I think you mentioned it already. I think it's about moving the decision to the patient to decide how much information they want to share and when and so on, to get the control of that. So again, this is part of the mitigation strategy to discuss.
Okay, great. It sounds like very exciting. I often hear many conversations, obviously, about patient data agency in the healthcare sector, something we constantly talk about with volunteers in the healthcare life science practice. So good to see that that still continues to be top of mind for everyone. So our next group 3 is technology and policy consideration in connected healthcare. So either Shane or Farrell? Hopefully I said your name right. I don't know who's been nominated to present on the outcomes of that session.
I'll start and then pass it on to Shane to provide some of the information about the recommendations that were identified in the group. We spent time discussing the infrastructure that's required for healthcare systems and for providing the secure connectivity. The house analogy was used in that you have devices that are inside the house and private versus those that are public. A lot of time was spent focused on data, the flow and liquidity of interoperability is weighted, where the term data equity was used. We want data to be volumetric and don't want other data to get in the way as you're processing that data. So that less relevant data can be taken out so that the most important data is available for decision making. Using predictive analytics, where you have an instance that's presented, and then with predictive analytics, you can identify some best experience and an advisement specific to that experience, that particular situation. So timeliness of data is very important, the real-time access to data, and being able to balance between the seamless user experience and user friendliness with data safety. Communication was another area where we focused in on having a guaranteed minimum bandwidth for real-time healthcare service, encrypted as well as secure. And then IoT devices, having some kind of a concentrator for various devices. One of the issues is the issue of interoperability between all of these different devices that are between hospitals for tracking. Even devices that are within a room may not necessarily be interoperate with one another. Voice-enabled devices, communication platforms to provide timely communication between clinicians. Allowing audio archival and proxy calling to better monitor high data equity exchanges. A question that came up is, you know, how can we identify that devices are from reputable players? Can technology optimize the human capacity to perform? Interoperability and standards kept coming up. If you have the same supplier of devices, it's a little bit easier to provide that interoperability. But then what happens when you have various vendors and suppliers and providing for standards, as well as the challenge of enforcing the policies that have been set. Identification, authentication, as well as standardization of devices for IoT devices was discussed as well. And Shane is going to provide some of the recommendations.
Yeah, as for the solutions, we had an extensive discussion as well. So I think the first and the priority would be the standard. So we need to have the vendors, and not only the device vendors, but also the software, even the telecommunication provider can sit down together and to know, first define what would be the technology need. And we need to understand what will be the interfacing. Then we need to have the standard to coordinate each other and all the software device level, even the communication level, so we can provide the comprehensive technical plan to have every single person speak the same technical language. Of course, the interoperability will not only focus on the technology itself, infrastructure should be considered as well. As we mentioned that in the beginning, the infrastructure could be the key challenge. And the infrastructure, not only just like a server communication, but if you look at the current Texas disaster, electricity, heat, water, those could be the important aspects. Well, you don't want to have the remote surgery being interrupted by like losing heat, electricity, something like this. So that also and move on to another perspective in the policy. So when we have a policy to enforce this kind of standard or try to have a players sit down together to have the same agreeable technical spec. So should the government step in or not? Or the government can help to have players define the terms of agreement or technical specs accordingly. Yeah. And that's an important part, although it's not very successful in the past 10 or 20 years, but we think that could be an important aspect as well. And not only just within a single country, but when you have across the country connected healthcare providing, for example, in Julian's keynote, he mentioned an Ebola case. The patient could be in Africa, but the healthcare provider could be in Europe doing like a remote telemedicine. So in this kind of across country connected health providing, we may need to have more players, not only just commercial vendors, but also the government to help to facilitate this technology. The third one is regarding the use cases. I think every single use case is different. For example, in the telemedicine, we also have many different types. Could be the remote surgery, could be just a consultant. And for the data access, we can have a public cloud or private cloud. So every single use case is different. So we need to be precise about what kind of areas we want to focus on, and then we want to have a full stack integration, because some areas not really so critical, but some areas will have much more requirements. Yeah, so I think these are like 3 major points for our solution and recommendation. I'll stop here.
That was excellent. You're all excellent. I'm so inspired by all of you. Julian was asking a question, a clarifying question in the chat regarding the concentrator. Is it an integration platform or other intent? You know, because I think of, we have routers at home. There are some, you know, device manufacturers where there's a bedside device, you know, where your implanted device connects to that and then phones home. So as you talk about the concentrator and that idea, what was the intent of that?
Yeah, based on my notes, it was from to have a hub where all of that connects the data from the IoT devices. But if others can jump in, that would be great for both for between hospitals, for tracking data, as well as for getting information from just devices in one room.
This is David from one of the other groups. There are some cloud services that will intake data from different manufacturers and put them into dashboards. And Julian probably knows some of these.
Yeah, I think, you know, I heard the word concentrator, and it stimulated the question, because we have to think, kind of drill down a little bit. You know, there's the kind of cloud-based solutions that are data aggregators or concentrators and do a lot of very useful things. But you know, let's talk about some of the use cases we talked about this morning. If you're going to adjust a ventilator in a patient's room, would you use that data and then control the device for that purpose? You know, is it reliable enough? Is it timely enough? Is it fast enough? And would you use that data pathway to display the data from a device? On the other hand, that type of data concentrator that's cloud-based would be perfectly adequate for so many other clinical applications. For example, making recommendations to a patient based upon information from a glucometer and a host of other things. So I think, you know, that's why I think I tend to think of it more as when there's some real timeness and data trust and communication, again, more real time, that especially in high acuity environments, we tend to think more platform based. And then as we think more about cloud data concentrators, it tends to imply another set of use cases. And in 20 years, there may be no difference whatsoever.
Actually, what related to that, something that came up in the discussion that I did not cover was just the transference latency. So if you're a user on one end, you may have a certain view with regard to the user interface that's available to you, but then when the data gets transferred, the person on the other end may not have all of the same technology to be able to have the same view.
Yeah, Faro, there's an interesting, there's research that we're doing right now in our lab on kind of real-time systems for autonomous care. And we've been scratching our heads over the implications of, let's say you have a connected system, maybe it's a platform-based system, you have multiple sensors, and you have multiple, perhaps either closed-loop control algorithms or decision support algorithms or alarm algorithms. How do we ensure that they have the same, they're operating on the same data sets? Because if they don't, good luck ever troubleshooting a system like that or tracking how you ended up with recommendations. And so we've been looking at different technologies that have been designed very much for that purpose, like used in robotic operating systems, for example, for that reason, and others which are simpler and easier and just kind of push data around for other purposes. But you're touching on this vital piece of, as we become, move to more advanced capabilities, and even, I hate to use the words over and over again, let's say machine learning, because it's too easy, but you have to ensure you're using the same data set. It's one thing if it's a static data set that you're pulling from, but if it's a dynamic or real-time data set, it might be different data if you don't have a way to ensure. In an autonomous vehicle, you darn well better be sure you're using it. So
in metric or English units. Hey, that crashed the Mars lander.
Cooking.
Mars
right.
orbiter.
It's ruined a lot of recipes too.
Very interesting. So one more thing I'd like to ask is, we've been hearing data acuity from Faru and from Julian. Can someone just explain that for listeners who may be listening to this afterward, who may think it's data equity, but it's really acuity, and what it means?
How it was explained during our session was that data has weights. So the most relevant, so we want to have access to a lot of data. However, we want to make sure we have access to the most relevant data. And so how do you make that most relevant data available in real time at a moment where a decision needs to be made, and be able to have access to that the level of data that you need. So someone else might be able to explain it more, but that's what I got out of our discussion.
I
think that's good. I was referring to something else, not data acuity, but high acuity clinical use cases. That's what I meant by acuity. But I think, not to undermine, or that was a great point, and I liked it, and I want to hear more. And I'm sorry to interrupt you, Nada, but I was referring to patient kind of high acuity, such as closed loop control of, say, a blood pressure medication versus making adjustments to someone's insulin regimen at home, which we have a different time scale and so forth, and maybe a human in the loop. Sorry.
Sorry, I just wanted to add into that. This is for the real-time system, autonomous care. So kind of you are dealing with a lot of data in real time. How do you make sure that you have time to clean the data before doing any work on it? Kind of remove any empty data or out of range and so on. It's a very, before you apply any algorithm or use it for algorithm.
Is Is that a question for me? Should I take that?
Yes.
Oh.
Sorry, Florence.
Oh,
Oh, no, that's fine. Yeah, because you're a
Okay.
real practitioner from all these different angles, Julie, and so your opinion is very valued.
I have to tell you that you just, asked me a question that's actually the most near and dear to my heart than most of the other topics. In fact, I started working on real-time physiological signal analysis using neural networks and fuzzy logic in the mid-1990s, and built real-time systems and rolled them around on computers in the OR and ICU, and they diagnosed patient problems in real time. Also used them for cardiopulmonary bypass, for clinical decision support using fuzzy logic. And that's exactly what I used to work on, was single signal, and I call it single signal analysis. Is this signal reasonable, or is it garbage? Is it representative of a patient's physiology, or does it have characteristics that are very clearly understood that are foreseeably wrong? Like if a patient has an invasive arterial blood pressure line, there are some things that they're out of range numbers, so you know it's wrong. There could be a square wave. A square wave is caused by flushing the line to clear it. It's not physiological. It could have highly dampened response, which is also typical of a kinked or an air bubble. So there's a lot you can do, and that's true with ECG. With pretty much most waveforms, there are these foreseeable alterations, including just out of range, but it's much more than that. They're morphological characteristics. And in doing those single signal analyses, again, the value of a platform-based approach is you can acquire signals at high fidelity. You can analyze those signals in a kind of a pre-processing approach, or there's a million different ways, right? Whatever makes sense, whatever technology and approach. And then you could decide whether you feed those signals into the larger system. Otherwise, you're feeding in garbage. And you can't, there may be subtle issues, but there are many things that the devices themselves can determine are problems. The gain settings are at maximum, or the patient, their physiological characteristics or morphological characteristics. And that's where I started my work on for neural networks, fuzzy logic, was to address that problem. And I actually shifted my work, my research pathway, because it didn't matter. I had working systems years ago, but without interoperability, without the means to connect and do anything else, it was a waste of time. There was no way to deploy those algorithms on other platforms. So you just kind of triggered the real history of how I got into this. In the 90s, these things were working, and they worked just fine, and they diagnosed problems, but there was no way to deploy and adopt. So I took a different pathway to try to help.
Can I add to that? In cybersecurity, when you talk about data quality, you just jump into a huge area. And in cybersecurity, we talk about not just confidentiality, but integrity and availability. Well, data integrity is a part of it. And I always think of it in terms of, are we collecting the right data, and are we collecting it right? I used to do environmental sampling and environmental lab work, and you're measuring at the part per billion range, and you really got to know whether you're getting the right information, because you're making big decisions on it.
So David, if I can, I'll comment that I just spent the last 3 days working on analyzing and working on a paper and some other stuff around autonomous systems. And the first step in this at the simplest level is trying to explain that we're shifting from a world with a human in the loop, who is a clinician, nurse, could be a medical assistant. What do? You go, you get your blood pressure taken, or your temperature, or your pulse oximetry value, and they put the cuff on, they take it, and they go, oh, that's wrong, I'll take it again. Oh, step on the scale. Oh, that's impossible. I'll take it again. Right? That's what they do. They throw out the bad data. They are the filters at the front end. They're the first step. That happens everywhere, in the ICU, in the OR. And so that idea of being the right data, use whatever word I don't want to be too specific, but data that represents the physical state or the physiological state. If you're operating on something else, you're screwed. And so I think, like you just nailed it, David. And it's funny that you mentioned it. This has been my, couple of late nights this week dealing and trying to explain to people why this is such, it's the fundamental, it's the base of the pyramid. And you could, just to continue, you could argue, and people will, oh, that all comes out in the wash. That's what big data is for. And, that's what, gazillion mega shmegabytes are for, because it all disappears, right? That's how you can predict flu in the population, and you can do all that. But, it's like applying the quadratic equation and coming up with two answers, one a positive and one a negative value, and saying, oh yeah, one of these could be the patient's blood pressure. No, actually, they can't both be the patient's blood pressure, right? One of them is physically impossible. So if we ignore the physical realities or physiological and disease and pathophysiology and instrumentation and its technology, we're kind of like going to go down all these dead ends, hoping to get the right answer instead of basing it on sound principles, which is what I think you just pointed out, David. So
and we come right back to trust. Do you believe what you're reading?
Right. Absolutely.
Excellent discussion. So I'd like.
That's quite interesting. Sorry, just that exploratory data analysis is essential, and that's what I can connect that to what Julian's sentiment is and human in the loop. I'm so excited to hear that from you, Julian.
And I'll just add last one thing is baseline, right? You need to know what the real truth is before you jump into anything else. So.
Right, identify patterns, identify anomalies, and as we used to say in software, respect the problem. Don't try to overlook it, right?
Absolutely, Florence. Absolutely.
On that note,
we say ground truth. What is the ground truth?
You don't always know the truth. Sometimes you just know that something isn't true, and you have to accept that.
You do, and figure out why. Agreed. On that note, we'd like to go now to our fourth breakout that Mitch and David facilitated on software and hardware supply chain security and proactive risk management, which has been a very real challenge in the past few months, if not before. So would you like to do a little readout?
Absolutely. And I can handle the first part, David. And so we had a good talk about the challenges and risks, and some of the challenges that we talked about very specifically in medical devices, the need to have long-term device component software supports. So again, Julian, to your note, I remember hearing Dr. Halamka talk about this 6 years ago now at a conference in Boston, and he called out a specific vendor for their ancient operating systems. And we talked a lot about one of the other challenges being the procurement phase and screening. And the example we talked about was the new MDS2 form, which is now a NEMA standard, and how so far, the example I gave my organization, I have seen these form from 2 vendors. Here's the challenge. I have 1,300. And next, we talked a lot about the long-term operating environment support, because again, the average Linux kernel gets about 7 years of support. Microsoft Windows gets 10, and that's for a long-term support version of Microsoft Windows. Microsoft is changing things up like Linux, and you have the challenge of what are the devices' life cycles, 15 to 20 years. When you start taking a look at that time frame, you still got Windows 2000 floating around in hospitals because of certain vendors that bring good things to life that have MRIs that run that, and also the cloud puts another wrinkle into this, which is configuration change support. So so a lot of these devices now connect to the cloud. What happens when a med device vendor decides, hey, my cloud-based architecture, I'm going to switch that over from AWS to Azure? What happens? How do I update devices so I don't have a couple million bricks sitting around in people's hospitals? How do I coordinate that? That's another wrinkle we really haven't thought of yet. And also the lack of incentives for manufacturers to monitor each step and build in these secure practices, because very bluntly, no one's really asked. And oftentimes we find ourselves in a position of having to be the first one that asks. And I can't tell you how many times that's happened over the past year. And the other example, we talked a lot about SolarWinds, but there was a secondary example that happened where somebody put some fake Python packages containing malware in Python repositories to see who would download them. And 33 major companies, including Apple, were on that list. So we have a big concern about open source and libraries that are used and getting that manifest. And also that the FDA guidance is more of a recommendation than a quote unquote force of law, plus also combined with the lack of uniformity. Again, bringing back to Julian's point about interoperability that we had to deal with. So the gaps we identified were 4 key gaps, which were number 1, people don't know what they have to do. And the example I give is that under the HIPAA security rule, if you're a covered entity, you introduce devices into your environment, your organization is responsible for assessing and addressing the risks that these devices pose in your environment. And yet, if I were to go to 80% of my peers and tell them that didn't work in large academic medical centers, what do you think the answer would be? The answer would be, I have to do that. I don't have the resources. Most hospitals and health systems don't have those resources for risk assessments or contract negotiations. They don't even know how to search for materials from the manufacturers or vendors. Not everyone is BD or Philips. And there's a lack of prescriptive guidance, AKA you can't identify a breach until it happens. So we went from there and talking about that. And Dave, do you want to cover the mitigation strategy and recommendations?
Sure. So again, our task was to look at supply chain for both software and hardware. And the concept of a software bill of materials has become popular. We talked a little bit about the National Telecommunications, NTIA, and NIST, the National Standards and Technology Group. They have come out with guidance. We need to look at things at the procurement stage. Mitch mentioned this form that is more widely used now, or hopefully will be more widely used, to find out what the manufacturers have done to address security. And then I think we also mentioned earlier that the need to, on a day-to-day basis, do better job in the operating phase. Alignment with international standards is going to be important. The FDA and the EU medical device regulations are good examples, getting those synchronized. And we came to realize that we have a very fragmented environment. We have different states. Certainly we have the FDA guidance and HIPAA, but then states and individual local jurisdictions and individual organizations do things differently. So we need some top-down goal-oriented leadership as an antidote to this fragmentation. And we talked a little bit about the success that West Virginia has had in their vaccine and opioids programs, where there was this kind of top-down leadership. Then in recommendations, we touched on a number of things. Certainly we need a plan with well-established and reasonable goals to address these problems in supply chain security. And we need to move from theory to implementation. How are we going to do that? We need to provide incentives to manufacturers. We had one person on the call from a manufacturing company, and really, manufacturers in a tough place. They have to compete, but what are the incentives for them to make sure that security is up to par? One way we can address the legacy equipment issue, we recommend that there be a combination of incentives to update the stuff where it can't be readily updated, to make sure compensating controls are in place, and ultimately setting some deadlines for end of life. We also talked a little bit about a more ubiquitous platform. This sort of relates to what was talked about a little earlier about interoperability. We even thought about interoperability as a service. that we may never come to one single standard for the communications, but if we have services that can do the translating, that would be helpful. And then we provided some links to some resources from the Health Sector Council, Coordinating Council, NIST, and a few other things.
Excellent. Thank you so much. Anything else, Mitch and David? No?
Didn't really have anything else, but again, this is ever evolving, Florence. And again, also bring to the point of good data integrity. I want to make another point to Julian, and that is you can't have good data integrity unless you have a good supply chain and good data provenance across systems. And we all have to work together. And again, ultimately, if I can't verify that the data generated by a device has been accurately generated, then all bets are off for everything else, including the intelligent systems. And there's no way an intelligent system is going to compromise when you give it bad data. And that's a fatal assumption people are making.
Yeah. We use different types of it was kind of early artificial intelligence, I guess, in the mainframe years ago. We used to be VP of marketing strategy for the mainframe. And if we could identify that there was a piece of the machine that just wasn't acting right, we would vary it offline, put it in its room and put it offline. We would quiesce it. I wonder if, there's some, type of tools like that we could apply. It's going to have to be smart, and it's going to have to be taught. There's a machine learning side of it too, I think, but there's a lot to consider here. Julian, you were going to say something, I think.
I think unless something is a very sophisticated, cyber attack, if you're looking at it in a more plain way, then it's very important to have there's typically validation data. When making an observation or a measurement. So, if you check, for example, and that exists in so many ways, but just examples, blood pressure. If a blood pressure is markedly different in the current reading than it was 2 or 3 or 5 minutes ago, the first thing someone does is check it again. Yeah. Now, if the blood pressure is markedly different and there are other things to support that it should be different, let's say the patient's suddenly in pain and the pressure is high, then you don't rush to check it again thinking it's false because you now have other validating data. So, so unless something is really effective at intentionally manipulating the data, it's less likely to bypass kind of the current thoughtful data assurance approaches we have. And then even if we use something at the device level to prove that this data really came from that device, it still could be erroneous. I mean, again, I'm being just such a simple example, but a blood pressure cuff is handy. If it slips down from the arm to the forearm, which happens also, it will generate the wrong blood pressure. It'll still be the right device and it'll still be on the right patient, but it will no longer be applied correctly. And, there are analogs to this throughout all these discussions, of course, but I think there's this notion of the context or correlation and validation that we have to take into account. It's the reasonableness that we all use when we look at data. Like, does this really make sense? This can't be right. Let's check it. Could it really be, is it really 65 degrees outside today? Oh no, like someone changed the setting in my, weather app to Florida. We all do that. And so I think that's part of the challenge we have.
I agree.
I agree. And I think, again, I just want to make one final thing building on that, Julian. I've had discussions with a lot of people at Regan Street about this, because when you build these systems, you're right about those assumptions. You have to be more explicit about what you do.
So,
very well said.
Part of trust, it's not just can you trust the source from a perspective as somebody intervened and messed with it, but what's the quality to begin with?
Right. Yeah, excellent. So, and I think your point, David and Mitch, is differentiating this. This is something we can do in a framework or a construct for that, to make it easier to access these concepts when looking at data.
Very well said. Great discussion, which is what we were really hoping for in the last 15 minutes, is let's all come together and see what we think. And we think there's a lot more to do, I guess I would say. And I think a lot of us could be part of the solution. A lot of you already are. So I think we want to go to next steps. Oh, and it looks like I'm the one doing that. So so what we're going to do is we have recorded this session and we've recorded the breakouts too. Some of them started a little bit late, but all of them were recorded. I bopped into all of them. And they'll be available for on-demand viewing, and they'll notify us from IEEE when they become available. We're going to be working, the students at Columbia and I are going to be working together on a documented summary of the breakout session. So thank you to all the students for taking notes and for all the facilitation and the great discussions. And we'll be coming out with that probably in a few weeks. It's midterm week here at Columbia. So then they have to decompress from that. And then I have my midterm site review with NSF at the beginning of March. So we have a lot going on here, but in a few weeks, we should have something for all of you. And we'll notify you via email once it's published. And then at the close, we'll post the link in the chat to complete the post-event evaluation survey. And we'd love to hear your feedback. We're planning to do this workshop series, the workshop every couple of months. The next one is on privacy, ethics, and trust in connected healthcare, and it's on the 28th of April, 2021. We were thinking of this time frame. We tried to choose it so it wasn't way too late in Europe, but I don't know if it's working in Asia. So when you do the feedback form, if you could tell us what you think, that would be great. And then we're going to be looking at, we were very lucky to have Julian as a keynote for this session, and to stay with us the entire time, Julian. It's been a great discussion. As we look at the next meeting on privacy, ethics, and trust, we are thinking about perhaps a panel, because as a number of the discussions showed in the breakouts, when you talk about privacy, ethics, and trust, it's different around the world. Our cultures are different. Our expectations are different. What we think is important is different. The policies are different. So we're thinking about maybe a little panel. So I already have a few people in mind, but we haven't invited any of them yet. We wanted to see, what output we got from this meeting. So if you have anyone in mind, then you can actually put that in the evaluation form, or you could send an email directly to one of us. I'll put my email in the chat. It's fh2417@columbia.edu, but I'll put it in the chat. And then we'll be, looking at that. And please invite your colleagues to register for the workshop series, and then they'll be able to view the on-demand and live broadcasts, because we're very grateful that this is free. And thank you, IEEE, for all this support. And thank you all the facilitators and Julian for the keynote, and the student facilitators. You all did a wonderful job. All the participants for sharing so openly your thoughts, ideas, and risks, challenges that you see. And for Christina and Christian at IEEE for guiding us through all of this. We really appreciate it.
Yes, and I echo Florence's sentiments. Thank you, everybody. Julian, the facilitators, and of course, you all who attended and stayed through the end for your great contribution and questions and comments. This is what makes this event, even in a virtual platform, very, very exciting and inspiring. Just looking at the chat, I saw some are having some issues accessing the link to the evaluation form. What we'll do is we'll send a quick email to all the attendees, and basically just with the link, it's a Google form. So if hopefully you all can access Google platforms, but we'll send it via email. If not, another option might be just to cut and paste it and open your browser and directly into the browser outside of the platform, if you can do so. Apologies for the inconvenience on that. But again, we definitely appreciate if in one form or another you share your feedback with us. So with that, I think we have come to... Wait. Yep.
Wait, yeah, sorry. So I just looked at the URL when I pasted it into a browser, and it has an interesting URL, the very last word is form restricted, FORM restricted. So I don't know what that means. I'm not used to reading Google's URLs, but I can tell you I can't get it to work when pasting in another browser as well. So
I'll check with our marketing team. They're the one who developed it, the SA marketing team.
Okay.
So we'll just go back and tell them that we're having an issue and tell us to give us the cleaner version.
security strikes again. There it goes. Usability versus security.
There you go. And so it's doing exactly what it was told to do, it sounds like.
Fascinating.
So we have to watch what we tell them to do. So, and Maria, thank you so much for your partnership as always. It's really been a great journey and I'm so happy that it gets to continue.
Definitely. And we'll make these slides available for download. And, there's an appendix showing the different, standards projects that reflect some of the core concepts we talked about today. And obviously our industry connections programs, which are mostly what we like to call incubators for potential standards activities. But with that, I'd like to wish you all a great day. Enjoy your afternoon, evening, and we look forward to seeing you on April 28th for our next one. Take care.
Thank you.
Bye-bye.
Thank you, everyone.